Actually, I've got two questions. One, talking with physicians a couple of years ago, the whole question about reimbursements for remote interactions came up, and I wonder if that's been solved under the new Accountable Care Act or other things, because I think it really becomes a problem for the healthcare profession to deal with that when a lot of interactions are moving to the home or to a short iPad interaction or whatever. Second question is, how do you assure security for these remote interactions between the patient and the caregiver?
So great questions all around. And so on the first one, I think the issue there are incentives now to do more remote things. And I'll change your question a little bit. It's not just remote interactions with physicians. I think we're finding that doctors are expensive and not necessarily good at a lot of things. So having it's really the ability to have a remote interaction with the right provider at the right time. Your question about security is an interesting one because there's sort of two competing thoughts on how do you manage remote interaction. So who's got video conferencing on their phone? Right? So you can imagine you could take your phone and talk to your doctor and then put your camera somewhere to show them what's going on with you. And it might work, but doctors can reach, providers can reach a lot of people that way. But the extent of what they could do to you is not that great. There are other scenarios where there are companies that make it looks like a really large phone booth where you go inside and there's a high definition monitor, there's an otoscope for your ears, and it's a camera for rashes, and there's a stethoscope that a remote provider can listen to. And so you can do a lot more there, and you can do, you have secure lines and everything else going with that. But again, you need those facilities set up. So how many people can you reach? How much can you cover? Who's visited a retail clinic, like a CVS Minute Clinic or one of those kind of places? So it's interesting, they provide really convenient care for about 17 conditions, right? If you don't have one of those things, they send you out. So it's the same kind of thing. We could do a lot of stuff and provide a lot of care, but there's a real dependence on the setting and the equipment that you can use at the time that's variable. One of the, if you go to UCLA just launched a program, sort of touching on both your questions, where it's sort of all you can eat mental health treatments via Skype with a mental health coach, and then you get 2 20-minute sessions with a psychiatrist, I think. It's like $99 a month. So we're seeing new models emerging where people are using these technologies. But the problem of people bringing devices into hospitals, using devices, accessing, getting on networks, has been a huge problem, and managing that security and having rules that keep up with it. And along with that, in the process of using your device, have you turned your phone into a medical device that's now going to be regulated by the FDA? Maybe Carrie wants to comment on that.
I'll get to that. But I did want to, coming back to reimbursement and business models, we continue to trip over those. And one of the barriers there for just any sort of remote mobile apps is, what is the scientific evidence base? So we are actually lacking scientific evidence that this works. There are certain efforts that have started. For example, Haptique is an effort to evaluate and potentially certify mobile medical apps. We have the National Institutes of Health is exploring the possibility of creating an mHealth public-private partnership so that we can actually figure out which technologies, do what they say they do, and is that what we really want them to do? And then even, in academic institutions like Hopkins are investigating this, but that's been another really challenging area, that until, we're always going to have that excuse, so until we can check that box or provide some of that evidence, unless folks take it on faith, it'll be, I think, a longer coming before we get there on the business model. FDA, and is your cell phone is not a medical device as it currently stands. No, this area has been really contentious for a while. It's got a lot of interest in the agency. There's a lot of interest in Capitol Hill, and before an election, it's, pretty dodgy. But the FDA has put out guidelines on mobile medical applications. Those came last summer. And the government has been asked to create a broader report over health IT regulation. So it's really important that we not get caught up with a general communications device. We have this premise, mobile is a platform for care. Yes, I mean, the two physicians in the room, I don't believe that you practice mobile health. You deliver health care. And so what we have to do is start looking at this more systemically, but it's really difficult from a regulatory perspective to keep the lines clean. So you want to just separate a device from software and talk about different platforms. And that's nice for checking a box of, okay, I know a software does this, fine. But when you have to make your whole system work together, so when you're integrating things, it doesn't matter where you find the software. It's just got to work from patient decisions and how all the data flows. We're still waiting to see what they're going to say. Right now, FDA has been very hands-off about the general communication devices. They are trying to let innovation flourish and just say, look, some things, applications that focus like function as medical devices are in fact medical devices, and if there's a serious risk of harm to a patient, then they need to be involved. As a patient and as reasonable people, if we were faced with a serious risk of harm, I think we would welcome that. So I'll stop there.
I would just add that, outside of the government sort of scope of this, we can also look to the commercial market, and there has been some emerging body of evidence related to things like EICU, where ICU patients at critical access hospitals are monitored via telemedicine at a centralized acute care academic medical center. And there's research now that's showing a return on investment in terms of financial investment on that. And if you really read the reports, you'll understand that not only is there an economic benefit, I think it was, again, a 24-month payback, if you will, in terms of the initial investment, but there's a quality benefit in that, normally those patients that are at those critical access hospitals would have to be transferred, med-flighted, ambulance, whatever, as well as their family members to the other facility, which is geographically disparate. So not only is there a financial incentive, but there's a quality of care incentive as well. To your security question, the thing that I would add to you there is I had an aha moment a few years ago when, we hear a lot about security. It's in the federal regs and HIPAA. But I had a patient who was a renal carcinoma patient. And basically what he said to me is, open kimono. If somebody can tell me what's going on with my particular type of renal carcinoma, look at all the information you want in my medical record. I don't care about security. I don't care about privacy. I care about getting well. So I think that we have to, obviously pay attention to security and privacy, but we also need to remember that we need the full data set in order to make strong clinical decisions for our patients.
And that hits on, a classic policy tension is individual preferences and risk tolerance are all going to change. Yet at a policy level, we're trying to set the rules for everyone, and it's a different distribution. Agencies a lot of times have almost what comes down to a dichotomous yes/no choice. And so that changes where you set that bar, because my preference and tolerance for risk is going to be different than Mike's and Mark's. And how are they going to come up with one set of rules that governs all of us?